This is a video demonstration of transoral ultrasonic surgery performed for a supraglottic cancer. Our patient is a 65-year-old gentleman with good performance status, smoker, presented with 2 months history of throat pain. Biopsy from epiglottic growth is squamous cell carcinoma. Tumor is involving the lingual and laryngeal surface and the tip of epiglottis. Laryngoepiglottic folds on either side, vallecula, and the arytenoids are free. Tumor just abuts the aryepiglottic folds and both the cords are mobile. This tumor is amenable to minimal access surgery through transoral route. These are the axial and sagittal cuts of contrast CT showing bulky proliferative growth involving suprahyoid epiglottis. Pre-epiglottic space is free and there are no suspicious neck nodes. CT thorax showed no distant metastasis, so the final diagnosis is carcinoma epiglottis, clinically T1N0M0. Microsurgery using carbon dioxide laser and transoral robotic surgery were classically described for such lesions. Transoral ultrasonic surgery is an economic alternative to these modalities. Spanish group led by Mario Fernandez first described this procedure. TOUSS surgery involves usage of various laparoscopic instruments and thunderbeat. Various laparoscopic instruments like grasping and dissecting forceps, cautery tips, and clip applicators come handy in this procedure. This picture depicts the position of operating team, the monitor, console of energy device, and the anesthetic equipment with respect to the operating table. Access to the tumor is achieved by suspending a Boyle Davis mouth gag. Tumor is visualized using a endo high flex scope docked using an endoscope holder. An assistant stays to the left of the operating surgeon and takes control of the endo high flex scope. Assistant, whenever required, changes the viewing angle using the joystick. A right-handed surgeon would hold a grasper in his left hand for the purpose of traction, a cautery tip or a dissecting forceps in his right hand to cut or dissect the tissue. In this case, we used a harmonic instead of a thunderbeat to cut the tissue. Dissection commences with separation of epiglottis from left lateral pharyngeal wall. Left pharyngoepiglottic fold is incised with a margin of 5 mm away from the tumor. A branch of superior laryngeal artery is often encountered within the pharyngoepiglottic fold, which needs to be cauterized or clipped to devascularize the tumor and thus avoid troublesome bleeding. Here we can notice the superior part of posterior thyroid lamina coming into visualization. Always mucosal cuts have to be taken under proper vision. After finishing dissection on left side, now the camera is angulated to right using the joystick. In case of fogging, the camera tip has to be flushed with hot saline to regain better visibility. As the right pharyngoepiglottic fold is free of disease, mucosal cuts are made over the right aryepiglottic fold. Now the cuts are made through the epiglottic cartilage. Even cold instruments like scissor can also be used for this purpose. Now the mucosal cuts are being made at the junction of base of tongue and vallecula. Exposure to this area can be improved by performing various maneuvers like withdrawing the tongue blade, external pressure over hyoid, and good counter traction over specimen using a suction or a grasper. Further dissection is performed into the preepiglottic space. Now we can notice the preepiglottic fat popping out. Now the mucosal cuts are being made over the right aryepiglottic fold. Now we are progressing our mucosal cuts towards the petiole of epiglottis. Final soft tissue attachments with the preepiglottic space are released. Petiole of epiglottis is incised using a fine laparoscopic scissor. Further dissection continues in the preepiglottic space using the harmonic scalpel. This is a type 2B endoscopic supraglottic laryngectomy without resection of preepiglottic space as per European Laryngology Society classification for supraglottic resections. Patient selection is very important in choosing a supraglottic tumor for TOUSS surgery. Patient-related factors like laryngoscore and various tumor-related factors have to be taken into account. Mucosal attachments at the base of epiglottis are released to deliver the specimen. Now you can notice the specimen delivered in toto. This is the final appearance of the postoperative defect with intact false chords and true chords. Histopathology is suggestive of a pathologically T1 tumor with clear margins and no metastatic nodes. Patient was decannulated on postoperative day 13 and feeding tube was removed after 2.5 months. This is the fiber optic laryngoscopy 3 months after surgery. We can notice good mucosalization without any scar tissue. Both the cords are mobile and the voice is good. Patient swallowing function is normal without any aspiration. This is another patient for whom a TOUSS surgery was performed. This gentleman is 56-year-old man with good performance status, smoker with history of coronary angioplasty in the past. He presented with painful swallowing for 2 months and was diagnosed to have stage 1 epiglottic cancer. This is a fiber optic laryngoscopic picture of another patient with epiglottic tumor who underwent TOUSS guided resection of supraglottic cancer. These are the sagittal cuts of a contrast enhanced CT showing epiglottic tumor confined to the epiglottis and pre-epiglottic space is free. There are no suspicious cervical nodes. We performed a TOUSS guided epiglotectomy and tracheostomy, and an interval neck dissection was performed after 4 weeks. Histopathology is suggestive of a T1 epiglottic tumor with clear margins. A node was positive in right level to a 1 cm without any. The patient was administered adjuvant radiation. This is a video of post-operative scopy with good healing and voice outcome. Post-operative course was uneventful. Thank you for watching this patiently.